we're kind of like a year further along. Yeah, so I'm excited to get into a little bit more of the nitty gritty of the interplay of the menstrual cycle, contraception, psychiatric illness, and psychiatric treatment. As always, feel free to kind of shout out any questions. Just press this here. I just can't see anything inside of the chat. Okay. I also recognize I tend to speak a little bit quickly, so feel free to like shout out to me if I'm going a little bit too fast. All right. Thanks so much. Can everyone see the screen here? Wonderful. Okay. All right. So why is this topic important? So I don't think I need to belabor this point to this group too much, right? But when we think about kind of like the different systems here of psychiatric illness, menstrual cycle, and some of the symptoms related to it, it's important to recognize just how common this is, right? So for example, when we're talking about just like menstrual periods in general, women on average have about 480, and that number changes based on when there's pregnancies. And then we think about kind of how common hormonal contraceptives are. About 80% of women in their lifetime will use some type of hormonal contraceptive at some point. And then this data here is from the CDC, and it's kind of just looking at more of like a point prevalence. And we see that in terms of women using any type of contraceptive method, about 25% in this moment, and this is based more on like 2017 data, are using some type of hormonal contraception. Okay, wonderful. And so for today, we're going to be splitting this talk into two different pieces. And so the first part one, is we're going to spend the majority of our time, and that's going to be going over menstrual cycle, psychiatric symptoms and illnesses. And we're going to look at the menstrual cycle and go into that for it, try to understand the differences between PMS, PMDD, and PME, and then look at some of the different treatment options for these menstrually related syndromes. And then our second part, we'll spend a little bit less time on, is hormonal contraceptions and psychiatric symptoms and illness. And so we're going to look at both, reviewing like how hormonal contraceptives can affect psychiatric symptoms, and then also looking at the interactions between some of our hormonal contraceptives and psychiatric medications. Okay, great. All right. So I'm going to start first with the menstrual cycle overview, because I think this is really going to, one, it's complicated, and I think just having this as a refresher is always really helpful. And then it's really important when we're thinking about kind of like the pathophysiology of kind of PMS and PMDD. Okay, so I'm going to start first kind of like going over what is on the different axes. And so I like this particular graph because it really shows different parts within like the body. And see the ovarian cycle, and so we're going to be looking predominantly at the follicles. You see the anterior pituitary hormones, and particularly looking at luteinizing hormone and FSH. We also have a section here with the ovarian hormones, so estradiol and progesterone. And then there's also a section down here where you're looking at what's happening to the uterine lining during this period. And then we're thinking about the menstrual cycle. Sorry, thought I heard a question there. And so if you look down here on this axis, we're kind of looking at time. And this shows kind of like a 0 to 28 day in terms of the menstrual cycle. It's important to note that only about kind of like 10 to 20% of women actually have exactly 28-day cycles. Most it's averaging between 24 and 38. Okay. And then in terms of kind of cycles being regular, about 20% of people actually have irregular cycles. So just something to always keep in mind when we're thinking through this. And so we're going to start here first at day 0. All right. So at day 0, you see pretty low levels of both the pituitary hormones, FSH and LH, as well as the ovarian hormones, estrogen and progesterone. And with low levels, you actually end up, when there's low level expression in progesterone, there isn't maintenance of the uterine lining. And so you're actually seeing what this is trying to represent with the dots is the bleeding period, right, of menses. Okay. But so we're at the start of the cycle, and the first thing we're thinking about is follicles. And the kind of purpose of the menstrual cycle is the development of follicles and ovulation for potentially so that there can be fertilization later. And so the anterior pituitary gland is going to release FSH, right, which is follicular stimulating hormone, and that's going to stimulate the growth of follicles. And then luteinizing hormone is also released, and that's going to stimulate some other cells within the ovaries as well that are directly related to the follicles. Both of those mechanisms are going to lead to more estrogen being produced, okay? So that's why we see this estradiol amount starts to increase. There's less of an effect on the progesterone. And so we're following this along. And you see as estrogen starts to increase, we see the uterine lining is starting to develop again a little bit, because a little bit of increased estrogen will kind of promote that. And then all of a sudden, though, we hit like this kind of peak, not exactly a peak, but a high level of estrogen. And something weird kind of happens. You actually get this negative feedback on the pituitary gland. And you actually see a little decrease in FSH and LH, right? But nonetheless, the follicle has already been, let me say this another way. And what this is actually representing here, this like increase in estradiol, is that the follicle is relatively like ready for ovulation. It's like grown. And so you get this decrease, and then suddenly, because there's still more estradiol being produced, there ends up being like this then positive feedback mechanism. And we get a really significant surge in the luteal hormone. And when the luteal hormone comes, when it hits this peak, that's actually when we get the ovulation, okay? And then we see the egg being released, all right? And this also signifies the end of this follicular phase, which is all about the development of the follicle, and moves us over to the luteal phase, okay? So when the ovulation occurs, what we're left with is this body here, which is known as the corpus luteum, but also known as the yellow body. And what that does is it's predominantly going to be producing progesterone. And why that's important to note is because you actually see a very quick drop off of estradiol after ovulation. That's because the follicle, which was producing all the estrogen, is no longer doing that. You see this very kind of quick drop off period, okay? And so the corpus luteum, its role is to get the uterine lining ready for potential implantation if there is fertilization of the egg. All right. And so you start to see it's producing progesterone, and the progesterone increases the lining and also increases the risk of, also increases the development of spiral arteries, which you can see those here. Okay. And so you're seeing this grow and grow and grow. But the corpus luteum needs LH or HCG to actually maintain itself. That's not going to happen if there isn't a pregnancy. And so it starts to decompose, and you see that over here. As it decomposes, you see the amount of progesterone go down, as well as the amount of estrogen, because a little bit ends up still being produced during this time. And after it reaches a certain point of degradation and low hormone levels, we're back to the start of the initiation of menses, and you start getting that shedding of the blood flow, okay? So this system is really important because when we're thinking about kind of like PMS and PMDD, it's the belief of kind of the, it's believed that it's not due to kind of abnormal hormone levels, but it's more due to a particular sensitivity to the changes in the hormone levels that we see. And the majority of kind of like PMS, PMDD symptoms are going to be occurring in this luteal phase, and predominantly during this kind of like late luteal phase. So from here onward, and we'll get into this a little bit more in detail. Any questions so far about the menstrual cycle? Because definitely quite complicated. Wonderful. All right, great. So I just wanted to kind of like name the different terms that you hear about when people are talking about PMS and PMDD and things like that. So the first one that we see here is just this general kind of idea of like premenstrual symptoms. And this is really kind of like a catch-all for any symptoms that individuals may feel during that luteal phase. And about 95% of women experience some amount of premenstrual symptoms sometime in their lifetime, okay? Then we move on to what's considered premenstrual syndrome, and this is something that ACOG defines, and we'll go over that a little bit more later. But we see that about 20 to 40% of women experience what is called premenstrual syndrome, and that's a more it's a more significant severity than over here. But then we keep kind of moving further in terms of like the severity pattern, and we get premenstrual mood disorder, and that's in both ACOG and the DSM-5. And this is rated about 3 to 5% of women experiencing these symptoms. Okay, and then over here, which is particularly, I think, important to our field of work, is premenstrual mood exacerbations. And so this is really encompassing women who have a different kind of primary psychiatric illness, and them seeing exacerbations during that luteal phase. And there is some evidence that it's about 60% of women who actually experience this. Okay. Wonderful. Okay. So moving on to PMS and with the ACOG definition. So PMS, or premenstrual syndrome, can pretty much be diagnosed if a patient reports at least one of the following affective or somatic symptoms during 5 days before menses, right? And so for affective symptoms, that's going to include things such as angry outbursts, anxiety, confusion, depression, irritability, and social withdrawal. And then for somatic symptoms, abdominal bloating, breast tenderness, headaches, joint and muscle pain, swelling, weight gain, and then something not here, but it's relatively common as well, would be something like insomnia. All right. And in general, these symptoms are considered kind of lower on the scale of severity. They tend not to significantly affect someone's functioning. Okay. But then we move on to PMDD, which is something that in our line of work, we likely see quite a bit more than some of the other ones. And so PMDD, this is really one of the big differences is just the amount of symptoms and the severity of it. And so in order to meet criteria, you have to have a total of 5 symptoms here. and at least one of them must be matched in criterion B. And so that has to be marked affective lability, marked irritability, marked depressed mood, or marked anxiety, okay? And then you also need one from criterion C as well. And the way I think about criterion C, it's pretty much like, it's almost like the major depressive categories plus somatic symptoms. And so one is decreased interest, subjective difficulty in concentration, fatigue, change in appetite, hypersomnia or insomnia, via a sense of being overwhelmed or out of control, and then some of these physical symptoms of breast tenderness, swelling, joint or muscle pain. Okay, and then here these symptoms are associated with significant clinical distress. All right, and then I think just criterion E is important to mention, that this disturbance is not an exacerbation of symptoms of another disorder, because that separates it out from PME. Okay, so for premenstrual mood exacerbation. So for PMS and PMDD, we'll spend a lot more time kind of going into the pathophysiology and treatment, but I actually put most of that information for PME just into this one slide. And the big reason of that is because we actually just have less data on it, okay? But in general, so when we're thinking about PME, the majority of the literature right now is actually within bipolar disorder, but it has been shown to be present for the majority of our psychiatric illnesses. And so we see that with anxiety disorders, psychotic disorders, personality disorders, and eating disorders. Particularly with eating disorders, there's a little bit more research out there around binge eating disorder, with the idea that within PMS, one of like the common symptoms we might see is cravings, and that this might actually trigger some of the binging behaviors during this time period. Okay. I'm actually going to bring our attention to this study down here, which is one of the major ones that was done. This is called the longitudinal follow-up of bipolar disorder and women with premenstrual exacerbation, findings from the STEP-BD study. And I like this one a lot because what they actually do here is they looked at about almost 300 women with bipolar disorder, and they actually followed them prospectively for a year as part of the STEP treatment. And they found that about 62% of these individuals had premenstrual symptom exacerbation. And then really importantly, they found that those individuals had a worse course of illness, shorter time to relapse, and greater symptoms in general. And this is something that actually fits with the patient I had actually presented last year, where most of her symptoms, or in particular like her periods of like high suicidality, as well as her periods of hospitalization, almost all of them correlated with the luteal phase for her, right? And so there's something really important to kind of think about when we're talking to our patients and understand if that kind of like cyclicality is there when treating. Okay, wonderful. And then in terms of kind of like why we think this happens, it is believed that it's similar to the pathogenesis for like in general PMS and PMDD. And it's more about, again, kind of like a reaction to normal hormonal levels, and particularly this, and I'll go into it more, but just like these changes in the hormones, right? And that it might be increasing the risk for having certain symptoms. In terms of treatment, some of the treatment can be the same with PMDD, but in general, the way that we tend to think about it for PME is you're using the primary treatment that's already being used for the type of psychiatric illness, and then increasing it during the luteal phase, right? So for example, if someone has bipolar disorder and they're well controlled with Abilify, let's say 20 for the majority of the time, but you do notice that there's symptom exacerbations in the luteal phase, increasing that a little bit during that period. And that right now is the kind of like most common way in which we treat PME. Great. Any questions about that? All right. So I'm just going to talk briefly about kind of screening tools and how we diagnose some of these mental syndromes. So clinically, or I shouldn't say, one of the common things you see in the literature is using the daily record of severity of problems, which I don't know how many of you guys have seen this. It's very clunky in my personal opinion, and I put it here. And I really haven't had many patients who feel open to kind of like sitting and doing the daily record of severity of problems. And so what I have found to be more helpful, though it's not invalidated, is actually using some like online tracker tools. And so I don't know how many of you guys have used Clue or your patients have used Clue, but I find it to be very useful. And so I actually just like took some pictures here of my phone of Clue and have them here. And it's nice because if you actually like really get into the Clue app, even the free version of it, you can actually have people choose what they want to be tracking, and they're able to send you those, okay? And it's able to give you the free version 3 months of symptoms, which is really nice. Okay. Great. So thinking about risk for premenstrual symptoms. Or premenstrual syndromes. So there is a positive correlation between PMS scores and increased prevalence of metabolic syndrome. The idea that it might be related to adiposity, and then how different like how the hormones kind of like are the reaction to the hormones gets changed with that. And then there's some evidence that potentially diet may play a role, with higher risk being like high potassium diets. And then some diets actually might decrease the risk. And so that's things that are high in iron, zinc, thiamine, and riboflavin. And then smoking is expected to potentially increase the risk of premenstrual syndrome as well. So that brings us to this slide, which I like a lot. And I think it does a really nice kind of overview of going over the different things that might be potentially increasing the risk of PMDD. And so this image here is kind of what we call the 5 interwoven pieces of the PMDD puzzle, okay? And each of these factors are kind of shown to influence one another and then may directly or indirectly contribute to the pathophysiology of PMDD. So I'm going to start here with brain structure and function. So there are a lot of kind of like new, honestly, really cool and new interesting research and articles out there around some of the brain changes that might be seen with individuals with PMDD. And some of that is changes in the amygdala and the hippocampus, right? And then over here, we can kind of thinking about genetics and heritability. So there is some evidence that there is like a heritable increased risk for PMDD as well. And then for progesterone metabolites. So there's been a lot of kind of information about this in the media. And I'm actually going to bring us over here to describe it a little bit better. So progesterone, right, as you see, is one of the major kind of players within the menstrual cycle. And it has different metabolites. And one of its primary metabolites is something called allopregnanolone. And allopregnanolone works on the GABA A receptor. And for those who don't know, it's the same receptor that like alcohol and benzodiazepine work on, right? And there's this idea that it's a change in both the progesterone and its metabolite, and these fluctuations that potentially causes some of these PMS, PMD symptoms, right? And so it's complicated, and again, it's a little bit still theoretical right now, but there's this general idea that as you're increasing the progesterone or pregnenolone, right, normally pretty anxiogenic, right? Just like with benzos and alcohol, it's going to kind of like decrease your anxiety. But just like with benzos, and we can see this kind of like paradoxical reaction to high levels of it, there's some belief that at a certain point, some of the high levels might actually cause some symptoms. Then there's also this idea that it might be the withdrawal of the hormone that might increase the risk of there being symptoms. And so that might be why when you kind of come over here, that you start seeing increased risk of symptomatology during this period. So it's kind of this idea that like, once the body gets exposed to high level of progesterone and that sudden removal of it, that things get a little bit worse, okay? Great. And then moving over here to estrogen and serotonin, the exact pathology really isn't explored too much, but the general idea is that we know that estrogen affects kind of like serotonin receptors in reaction to different, to certain neurotransmitters. And you'll see with some of the treatment options that you're kind of focusing in on this as well, okay? And then over here, just for trauma, so there are some studies out there suggesting that a history of trauma increases your risk to having PMDD as well. Cool. All right. So when we're thinking through treatment options for PMS and PMDD, so there's really kind of 2 categories, and it makes sense when you're thinking about the pathophysiology of what actually causes these symptoms. And so when you look over here, right, again, this area of where PMDD is most likely is during this luteal phase, right? And so one of the treatment options is actually going to just stop that. And so you stop ovulation. So that's because you're going to see those over here. And there's both medications and surgeries. Then the other treatment option is, all right, well, you maintain ovulation, but you do other things to mitigate the risk of symptoms and the severities during that period. And there are behavioral ways to do that, pharmacologic, and supplements. We'll spend most of our time on pharmacologic and do some brief reviews over here. One that I do just want to bring up briefly on this slide, because we won't talk about it too much later, is isopranolol, which is another kind of GABA A agonist. So it's very similar to the allopregnanolone that I mentioned earlier. And it's very early. There's only been kind of like 2 trials right now, but there is some positive signaling that it might be helpful for PMDD treatment in the future. Okay, but it's not FDA approved right now. That's something you can give to your patients. All right, so behavioral intervention. So this is really kind of going to be that first line to be using, particularly with PMS. Often PMDD, using medications is often going to be needed for real kind of like symptom control. But we're thinking about behavioral interventions. The first is kind of changes in nutrition and activity modification. So just like I mentioned before, you know, there is some negative association with alcohol, smoking, sodium, and caffeine, and just continuing to recommend to have a decrease in that, okay? There's also a lot of recommendations around monthly mood charting. And so we actually know that if you have someone actually just kind of track their symptoms, just kind of understanding that cyclicality of it, seeing it and being able to be like, oh, like I know this day is coming. How can I prepare for this? Or, oh, maybe these symptoms are related to this change, and being able to kind of like recognize and stop has been shown to actually be quite helpful for many individuals. And then kind of even like moving a step further than that is like CBT that's directly related to this. There's actually a decent amount of evidence out there around kind of like internet-based or online CBT being really helpful for PMDD. Unfortunately, though, I could not find a single one that was actually translated into the real world that could be available for our patients to buy. So instead, there are some other like CBT apps in general that likely would be helpful during this period. And that includes things like Headspace, Calm, and Happify. And then I don't know if anyone else has had like this real question of like, what is an okay app to give my patients? Like I don't necessarily have the time to kind of like look through each one. There is this helpful guide online. It's called the One Mind Cyber Guide. And it actually does review mental health apps for credibility, user experience, transparency, and professional reviews. And so I put the link here for you guys to look at. It's a little bit convoluted, but still a helpful one if you have some questions. And then two other interventions that have some data on it, but honestly, not a huge amount, is light therapy and acupuncture. And then for those who have never seen it before, the Center for Environmental Therapeutic, which is based, or their primary person is here from Colombia. This is a really lovely site and gives a lot of information on light therapy. Great. Okay, so what about medications? So first line are SSRIs, right? And we know from various numerous trials at this point that they really are quite effective for treating PMDD. And on average, most of the studies suggest like a 70% improvement in symptom scoring compared to about 40% that you see with placebo. And that's been shown pretty consistently throughout. And so the question starts to become, well, then what's the appropriate dosing? And then what is the frequency of the dosing that we should be using? And so the first one that I'll talk about here in terms of frequency of use is the luteal phase dosing, right? And so again, you look back to that picture and we know it's a luteal phase that we're having predominant symptoms. And so what you do is you start on day 14 or whatever the day of ovulation is, right? And you can use Clue to kind of like help them determine that. And you start and you continue it until the menses starts. Some people, though, might need a few days into the menstrual cycle for the symptoms fully to resolve, and use your clinical judgment to kind of determine how long you want to keep that. And that's been shown to be quite efficacious. I'm going to skip this for a second and go over here to continuous dosing. So this is when you take the SSRIs throughout the entire period, right? So like day 1 to day 28, you just keep it there and you don't make any changes. And there are some potential benefits here with this one. One being that there might be a decreased risk of withdrawal symptoms, though I will say the studies with luteal phase don't tend to actually show significant withdrawal, but it does come up. And it actually might be slightly more effective. The evidence on how much more effective is a little bit up in the air. Not every meta-analysis shows that, but it still might be. And so these two are going to be your first line. They're relatively equal and something to trial out. Then you have something called symptom onset dosing, which I imagine is something that everyone sees clinically quite a bit. I know I've seen this with patients coming in and saying this. And the reality is there actually isn't that much information out there online about the efficacy of this. And what is there suggests that it's actually not as efficacious as the luteal phase and continuous dosing. One of the major studies suggested it was not much better than placebo. Okay. But again, using your clinical judgment and deciding if this is what worked best for the patient. Okay. And then we have something called continuous dosing with intermittent increase. And so what that is primarily is you're giving someone an SSRI throughout the entire month, and then during either the luteal phase or at symptom onset, you're increasing the dose, okay? This is generally used for those who tend to have a primary psychiatric illness that's already being treated with an SSRI with some of that exacerbation, right? And you're gonna increase that dose. Wonderful. Any questions about this? Great, okay. So then we're going to move on to other synergistic agents, right? Again, pathophysiology-wise, it would make sense that they work, and that's kind of what the evidence tells us. So for SNRIs, there is a lot less data, but there's more positive for duloxetine over venlafaxine. Venlafaxine is still expected to work. The main caveat there is that venlafaxine has a very short half-life, so there is a little bit more risk of having some withdrawal symptoms. Okay. And then for TCAs, there are only 2 articles out there. They're both on clomipramine using small doses, about 50, but it was shown to be efficacious for the patients as well. And I should say one thing just in terms of the SSRIs, in terms of the actual dose of the SSRIs, so the studies show kind of like varying amounts that have been used, including like low doses such as sertraline 50 and higher doses such as sertraline 200, and they all seem to be efficacious. So it's really about titrating it to what your patient needs. All right, so moving over to benzodiazepines, right? And so if you remember earlier, I was talking about the allopregnanolone, right, which was the metabolite of progesterone. And you can see that kind of here in this diagram. And it works directly on the GABA A receptors. And remember, there's this idea that it might be some of the withdrawal of allopregnanolone that might be causing some of the PMS symptoms. So it makes sense that potentially one of the treatment options would be something that works on the same receptors, and that's benzodiazepine. Most of the data suggesting that this actually works is from the 1990s, and they were usually looking at allopurinol, but it was shown to be effective, as well as it didn't have significant withdrawal symptoms too. Okay, so the stuff that they think about is like an adjunct medication if the SSRIs aren't working as well for your patient. And then antipsychotics. So this is not something that has been studied too much in the literature, but there was a research article in 2015 that did look at Seroquel, low-dose Seroquel for adjunctive for SSRI PMD treatment, and it was found to be effective. Okay, but again, when we're thinking about antipsychotics, we tend to be more thinking about like a PME and using it in that continuous intermittent way. All right, supplements. So I laugh when I say this, but when I started joining the women's program, I was doing a lot of research on PMDD and pregnancy. And so all of my like social media accounts think I either have the worst PMDD ever or I'm constantly pregnant. And they're always giving me these ads for these supplements. And the most common supplements that are coming to my social media handles now are Ollie, Hum, and Flow. And what all of these have in common is this kind of like newer to the market Vitrix cactus or chasteberry, right? And why it's kind of having its like moment right now was that there was this systematic review in 2017 that looked at 8 different randomized controlled trials, and it kind of put it together and said that there was a positive effect of the supplement on PMS symptoms with good toleration, right? But there's a pretty huge caveat there. When you actually look at the 8 different RCTs, they're very, very different. And they're all kind of low quality information. They use different like methods of dosing. So some of them are actually using liquid, whereas other ones are using like the pill form. They use different dosage amounts. And then even how they're rating PMS symptoms is different as well. Right, so there's really kind of like you want to take this study with a grain of salt, but it's definitely something that the media has like linked onto, and you end up seeing this stuff called the supplements now. The data that is there suggests that probably 20 milligrams is a bit effective. Most of these supplements have about 3 times that, around like 80. Okay, so something to be aware of. And then there was one study that actually did compare it with fluoxetine. They did find that it was better than placebo, but did not find it to be better than fluoxetine. So if you are using this as patients, again, you're thinking more around kind of like moderate PMS, mild PMS, and not so much where we move further to PMDD. Okay. And then one thing that had actually come up with my patient from last year was, can this interact in any way that might like worsen psychiatric illness? And right now there isn't any evidence out there that it would, but there's some idea that one of the potential ways that Vitrix cactus works is through like the dopamine system. And so just something to be mindful of if you do have a patient on any medication that's directly interacting with the dopamine system there. Great. All right. So we're going to move over to anovulatory options, okay? And so we're going to look at both medication and surgical here. All right, so the first is going to be combined oral contraceptives, or OCPs. So this is ACOG considered as number 2, second in line for treating PMDD, all right? And the idea here is that you are getting rid of those hormonal fluctuations that we talked about before, right? So this is again kind of like an overview of the normal menstrual cycle. And then with OCPs, you're giving someone estrogen and progesterone, right? And you're keeping the amount consistent during the whole time. And that also leads to consistency in the LH and FSH just due to the feedback mechanisms between them, right? And so you're not getting these changes that you would see during the luteal phase. And it has been shown to be effective with PMS, though it seemed to be less effective compared to SSRIs and has more higher risk associated with it, things like blood clots. So that's really why it's kind of second line compared to the SSRIs. Okay. But so we know OCPs work, but then the question becomes, what's the formulation and how should they be dosed when we're thinking about OCPs? And so traditional OCP dosing is 21 days of active pill, so that progesterone estrogen combination, and then 7 days of inactive pill, right? And that's kind of what we're seeing here. So when you're using them, you have these normal levels, and then you have this really sudden drop off, right, during the active, and then you come back up. And we, again, or I shouldn't say we know, but we theorize that the PMS symptoms are linked to these very quick changes that we see, okay? And so there have been a lot of questions of would continuous or 28-day cycle work better? The evidence out there is maybe, right? There's some positive signaling, but it's a little bit unclear how much more helpful this is. Again, this would be a moment of using your clinical judgment and seeing if it does work more for the patient, but it really might. Something else important in terms of this kind of like continuous 28-day cycle is this is safe, right? And I think this is a question that comes up a lot. It is not expected to increase risk of adverse effects significantly. Also, patients will sometimes bring up this question of, is it okay that I'm not getting my period? Well, it's important to remind them that the period that they have with OCPs is not actually a real period because there hasn't been any release or ovulation of the egg. And all they're actually seeing is that because there's still a little bit of estrogen and progesterone that they're getting through the pill, they're going to have some amount of uterine lining that gets built up, and then it just is going to shed when the estrogen and progesterone are gone. So it's more of a withdrawal bleeding, but it's not a true menses, and they do not need to have that. Okay. I'm also just going to mention another dosing schedule, which is YAS. So that's a 24/4-day, and YAS is it's FDA approved for treating PMDD. And part of the reason why they think that it might work a little bit better than some of the other OCPs, and again, like unclear how true that actually is more, it's partly due to this change, right? So the idea that there's less inactive pill days, and so there might be a decrease in some of the symptoms related to changes. Okay, but great. But so I mentioned one of the things was also like, what's the formulation of the OCP? So previously, the majority of the OCPs contain progesterones that are actually broken down from testosterone. And we can see that over here in this chart. And there was a belief that it had some increased risk in symptoms, predominantly symptoms involving kind of like bloating and some potential like depressive symptomatology as well. And so there became a question, well, if we use a different type of progesterone makeup, would that decrease the type of symptoms? And so drospirenone was created, and this is broken down from spironolactone. And so it's believed to potentially have less of a negative effect in terms of like symptoms or PMS. And one of the first ones that came out with this was Yaz and Yasmin. And then, as I mentioned before, it had FDA approval. Now, I don't know if you guys remember this, but I know I certainly do. There was this period a few years ago where everywhere in the news, it was like, come join us if you need to like do a lawsuit against Yasmin due to blood clots. And so this was like something that was very big in the media. And this was because in 2011, the FDA actually told Bayer they needed to change their label because they felt that Bayer was estimating how effective it was for PMDD, and then also underestimating the risk of blood clots. And that's because there were some studies done suggesting that drospirenone in particular might actually increase the risk of having blood clots. But further research has suggested that that absolute risk is quite low. And ACOG does not actually separate out drospirenone OCPs from other OCPs in terms of kind of its risk category. And so I'm just going to bring you to this slide over here. So when you look at any combination of like OC use, the risk of blood clots is about 3 to 9 out of 10,000. When you look at just drospirenone, that increases to about 9 to 10, right? Which really isn't a significant decrease. That absolute risk is quite low. And then it's also just important to remember that pregnancy and the postpartum period give you a much higher risk of having blood clots. Okay, so ACOG absolutely says that drospirenone are safe to use within OCPs. And again, something to think about if you have a patient coming in who wants to be on OCPs but have had negative reactions before. Also, it's important to know that Yaz isn't the only one. So there's various other contraceptives that contain Yaz. In case your patients are like me and like kind of remember these different ads, they really might not want this particular brand. And there's other ones that they can talk to their OB about. Great. Okay. Other hormonal treatments. So we're getting now to like third, fourth line, right? But these are really for the individuals who've tried these other things and they're just not working. So one that you see in the literature is something called danazol. And what it is it's a synthetic steroid with both androgenic and anti-gonadotropic properties. And the exact mechanism is a bit unclear, but it's believed to suppress ovarian activity by working on the production, on like how these hormones are actually produced. And then it also affects LH and FSH release. And then it's believed that it's going to stop ovulation. Okay. And so most of these studies are quite old. They're from the 1990s as well. And they suggest that doses around 100 BID to 200 BID can alleviate some PMS symptoms. It is not first line though, because it actually has a lot of negative effects. And that includes things like weight gain, hirsutism, and acne. Okay. But it is something that continues to be used today for more severe forms of PMDD. And then the other thing that we sometimes hear about is GnRH agonist. And so this is going to include things like lupride, glycerin, and hysterin. The way that it works, right, is that normally within like the body system, in order for you to have the menstrual cycle, you're actually going to have like the cyclical release of GnRH. But when you actually give someone a consistent amount of it, it does not actually allow the menstrual cycle to go forth in the way that we would expect it to. Okay. And you end up getting very kind of like low estrogen states from this. And so it's very effective at kind of like decreasing the symptoms of PMDD and PMS, because again, you're getting rid of those like hormonal fluctuations that you see in the luteal phase. But it also has a lot of negative consequences associated with it because of these low estrogen states. And so you're going to see like many symptoms you would expect kind of like from menopause. And so you're going to see night sweats, you can see risk for decreased mineral bone density, decreased libido, vaginal dryness, and night sweats. They've looked a little bit into if you can get kind of like add back to kind of like help with some of these symptoms. And what they found is when you actually do give the hormones back, people get the symptoms back, right? So there's a little bit of a limit to it. But what they're trying to do now, and I won't go into it too much, is that they've seen that if you give it back, right, but over time, the symptoms actually start to diminish, because it seems like it's just kind of like that initial add back period where there's like the fluctuation change. And so there's movement towards understanding what would be like the best time framework to decrease the amount of periods in which there's fluctuation. So there's more kind of like research going into this right now. Great. Okay. And so then last line is going to be surgery. And so there are numerous potential adverse effects here, from like musculoskeletal symptoms, some sexual difficulties, and various long-term risk. I'm not going to go into it too much, but there is this wonderful like hour-long didactic that was created by something called the International Association for PMDD, which is a really wonderful resource, and I put at the end of it here. But this goes pretty in depth in terms of surgery for PMDD. Well, cool. Okay. So I'm going to take a pause there because that was a lot of information before I go into part 2 and see if there's any questions or comments that people might have for that first piece. And I can't see anything in the chat, so there we go. Oh, would chasteberry be taken all throughout the cycle or just during the luteal phase? So that's a great question. So the majority of the studies I looked at used it as a continuous basis, but I think there were 2 that had it used just as a luteal phase, and both of those showed positive reaction compared to the placebo for them. And I think one of the important things for those studies is that it was well tolerated, right? So it wouldn't be something unreasonable to kind of trial out with your patient, okay? All right, so I'm gonna move.
I don't know if anyone has any suggestions about where to find sort of the better brands of that, on a practical basis. There's a lot that you get in the drugstore that's not necessarily at all therapeutic amounts. So I think that's one of the things to pay attention to.
Yeah, it's definitely hard to find. Ollie is in the drugstore, and that has 86, so you do see those there. Yeah, it's the only one I know in the drugstore. Great. Okay. So I apologize. Give me 1 second. My cat is begging to go outside, so I'm gonna go let him do that, and I'll come right back.
Yeah, while she's doing that, I'll just say that I've had a few patients, I've ended up doing ovarian suppression like Lupron with AdVac, and it's complicated, but it has been very helpful. So there's not a standard protocol for the hormones, the AdVac hormones, which makes it very complicated, and getting it right can be tricky because people absorb things differently through the patches, et cetera. And sex hormone binding globulin gets involved too in terms of the available hormones, et cetera. If someone's on multiple medications in particular, that's a problem. So anyway, it's complicated but doable, and maybe we can talk about a case in the future.
Wonderful. Great. And sorry about that, guys. But I imagine all of you who have pets at home understand what just happened. So, but in terms of moving on to part 2, so focusing a little bit more into contraceptives and psychiatric illness. And this, I mean, honestly, I think was just based so much on like the constant conversations and questionings of, do OCPs cause depression, right? And what's kind of like the link there. And so thinking first about kind of like these combined hormonal birth controls, most commonly OCPs. And it's a bit complicated because overall, most of the current studies do not suggest a general association between CHEs and depressive symptoms. However, these studies are likely like unreporting some potential individual differences and risk, right? And particularly for like our patient population. And so there's some belief that individuals with like baseline risk for psychiatric illnesses such as anxiety and depression may just react a little bit differently, right? And we might not be catching that. Additionally, a lot of the studies that you are looking at, even the ones that are prospective in nature, they end up doing their analysis on those who stay on the medication during the entire kind of treatment protocol. But you see a lot of individuals, up to 1/3 actually stop oral contraceptives and will often report kind of like depression or other kind of mood changes as like why they did it, but they're not always included in the analysis, right? So this answer is really, it's complicated. What you can kind of tell patients is that right now the data does not suggest that there would be an increased risk of this, right? And for someone who doesn't really have a significant history of depression or something like that, you can feel confident in recommending this medication to them. And at the same time, say, that we'll watch and kind of see how things go for you, because there can be a lot of individual differences when we're thinking about OCPs, okay? I am just going to bring our attention to one of the more kind of recent studies, because this is something that's been talked about a lot in the media. And there was actually this pretty large systemic review in 2021 that was done. And it actually included 12 different meta-analyses and about almost 6,000 participants. And you can see over here, they actually looked at 10 different combined contraceptive methods. Yeah, and so you see all these different ones here. And when they finally like completed the analysis, they really didn't find any differences. And they even broke it down into like progesterone only ones, and they didn't find any differences there. And so this is one of the more kind of like recent larger studies that really does suggest that at a population-based level, there shouldn't be a change in some of the depressive symptomatology. Wonderful. All right, but what about progesterone? Because there's a lot of particular question around, again, this idea of progesterone, particularly those that have like the testosterone base that they're coming from. And again, overall, current data does not support an association between progesterone-only birth control, right, and the worsening of depressive symptoms. With that said, though, there definitely is some positive signaling, particularly in some of the older studies around Depo-Provera. And as that one might be, have more of a potential link to having some adverse effects, okay? It's also really important to think about progesterone-only birth control when you're actually thinking about women who just gave birth, because as you saw earlier in an earlier slide, risk of any type of blood clot is quite high. And so birth control containing estrogen is actually not recommended in the immediate postpartum period. And so if you're really thinking through for someone who has like a history of very severe depression and elevated risk for postpartum depression, you might want to stay away from Depo, okay? And move more towards kind of like an IUD option. Okay. Wonderful. Great. Okay. So I want to just like take a second and actually just do like, imagine we had a patient and just go through some general recommendations of how to kind of think through these cases. And so for a brief clinical vignette, It's you have a 25-year-old female with no history of psychiatric illness, presents with worsening depressive symptoms after initiating OCPs. Right? We want to think about, well, what are our next steps? What are we actually trying to evaluate here? And the first is really just kind of looking for a primary mood disorder, right? Because in general, we know there's like a peak around this period of time. It might be if the OCPs are unmasking. There's all these different things, and you really want to look through, like, is there actually a primary mood disorder that's here? And then you want to just in general consider a switch to another birth control, because it might be, again, that this person's individual differences might be leading to some worsening symptoms directly related to the OCP. And so you want to think about potentially switching them over to a different one. And that can be an OCP potentially with drospirenone, or thinking about something like an IUD, which is just progesterone based. But then what if that person came in and they had a history of bipolar disorder and is on mood stabilizers, right? And so here, you want to think about the interactions between the medications and the OCPs, right? There are definitely a few of them, okay? And so I'm going to actually take us to the next slide, which gives, like, I put together a chart of the interactions to think about with our medications, right? In general, this slide is mood stabilizers. We really don't expect the SSRIs to have significant effect on our hormonal medications, okay? And so just the first two, lithium and gabapentin, in general, they're not expected to have an interaction with contraceptives, okay? But so then let's go through each of these. So you have Depakote, all right? Depakote is expected, the interaction between Depakote and OCPs is that OCPs are actually expected to decrease the Depakote level by about 30%. And the reason for this is that particularly estradiol ends up affecting the activity of the hormone that breaks down Depakote, okay? The clinical significance of this, it's pretty unclear, right? And again, it's going to be based on kind of with your patient and like kind of looking at if you're starting to notice a change in the premenstrual period. If you start noticing a change with OCPs, thinking about increasing it as needed, but there's no specific kind of guidelines out there. All right. For lamotrigine, again, you see a similar potential effect, but more. So hormonal contraceptives may decrease the lamotrigine level by as much as 50% and very quickly. You can see that within kind of like 1 to 2 days when someone's on an OCP. And then there might be a decrease of, and this is mainly due to the effect of estrogen again on the enzyme that breaks down lamotrigine, okay? And so when you're thinking about, again, lamotrigine, there's a few different things you want to think about. So use it in an inactive, kind of like for that normal way that we give OCPs at 21/7 day, right? You can really see a doubling of the lamotrigine during that 7-day of inactive pill, right? Because now you've removed the estrogen that was affecting the enzyme that broke down lamotrigine. And the risk that we potentially see here is actually a bit of toxicity with lamotrigine, okay? So you want to consider, there are very different things. One, don't make any change, right? If your patient has been like stable on this and has been able to like ride this through, there's no need to make a change, right? Each person's a little bit different in terms of how their body actually reacts with this. For number two, you can consider about a 25 to 50% drop of lamotrigine during that inactive week, right? And again, just being mindful and you can monitor it. You can do lamotrigine leveling. We tend not to recommend that. It's really kind of about like following what your patient clinically looks like, but it is something that you can use to kind of help you during this period. And then three, consider moving over to a continuous OCP dosing, right? As I mentioned before, it's safe to use these in a more consistent basis. And one of the common ones is seasonal, right? So that's something that you can think about too. And then for four, considering moving to a non-hormonal contraceptive method, such as an IUD, okay? Because we don't expect the progesterone that's released to have the same effect on the system. So you wouldn't expect to see the same amounts of like changes in lamotrigine. And even then, it would still be consistent, right? Okay. Any questions for lamotrigine? Because I know that's the one that tends to get asked a lot about. No. Lovely. All right. And so then moving over to carbamazepine and oxymazepine. So this one is opposite. Now, carbamazepine is expected to decrease the efficacy of OCPs. And how it does this is it's through the P450 induction. And so you get a decrease in both estrogen and progesterone. All right. So this is a really, really important one to think about. And I have it highlighted here. And that's because like carbamazepine is associated with decrease of efficacy of OCPs, and it is associated with more congenital abnormalities. And this kind of like doubling of that, of like, we're gonna make your birth control not work, and if you get pregnant, we're gonna increase the chance of you having congenital abnormality. That's something to really think about and a reason to consider moving someone over to a different type of contraceptive method, which is what I bolded here. You'll see a little bit in the literature this idea of giving someone high dose OCPs, but that's generally not recommended because we don't actually have studies proving that that works, that it doesn't really decrease the efficacy. And some of the older studies that was showing like breakthrough pregnancies was when we actually use higher doses of these medications. And so really you want to think about switching them over if possible. Then moving over to topiramate. So topiramate at certain doses, so we're really talking about like over 200 milligrams, it does actually, again, decrease the efficacy of some of these hormonal contraceptives. In the same way, it's also a P450 inducer, though a lighter one. Okay, this is one where, again, you might want to consider changing over to a different hormonal contraceptive versus maybe bumping up the level a little bit. But the effect definitely isn't significant as when it comes to carbamazepine. And the last one that I'll mention here is modafinil. There's been a lot more about this kind of in the media again lately. So modafinil, it's actually expected to decrease the efficacy of oral contraceptives. And it predominantly decreases the levels of estrogen. And it's believed to be through kind of like induction of the CYP3A4 pathway. And so they do, in general, you want to think about switching over to another birth control. It's similar to carbamazepine that, again, I've highlighted in red because it decreases the efficacy of oral contraception. And there's actually some new evidence suggesting that it increases the risk of congenital abnormality, actually as much as like 12%, which is much higher than that kind of like 3 to 5% that we think about for baseline risk congenital abnormalities. And so this is another one that you really want to talk to people about. Something else for modafinil. So there's actually been some more like news articles, actually more in the UK and less in the US, about this being used as like kind of like a college drug now in order to kind of like stay up and do like more work at night. And so there was like one kind of like, again, like not like super robust study, but it was suggesting that like maybe even like out of like one out of like 6 individuals in the UK were like using this medication. It's something to think about and just kind of like talking to your patients and really doing an assessment if they're using modafinil unprescribed and talking to them about the effective potentially of their OCPs. Great, okay. So then I'm going to end on some resources and a little bit different from the ones that we usually share. So one is the International Association of Premenstrual Disorders. It's a really lovely site that is both great for providers and patients as well, and it has some support groups there too. So if you have patients who are suffering from severe PMDD. And then ACOG, just a lot of information around the treatment of PMDD that can be helpful. And then for those of you who have seen kind of how I do my presentations before, you guys know that I always put like very specific references in the bottom and also kind of put summaries of any of the articles that we talked about. So those are there for you too. And as always, we'll send them out after the end of the seminar series. Great, okay. But so let me stop share and open up for questions and comments. I also love to hear people's experiences on PMDD and treating it with their patients. But.
Nicole, thanks so much. This was really, as usual, so great and thorough and a ton of information. And I think, very detailed and new information as well. So thank you so much for putting in the work to put this together.
Absolutely.
Betsy, is there time for me to ask a quick question? It's
Rachel.
Yeah,
please. Yeah.
Hi. I'd love to ask you, Nicole, or anybody, if anybody has any experience using or with having patients on hormonal IUDs, and if anyone has seen either any improvement in premenstrual symptoms. I've kind of like wondered if having that like leveled out a little bit in the way it seems to impact people's cycles, if that might be helpful. And also people are always asking if that's going to impact their mood. And I haven't seen it, but I wonder what other people are seeing.
Yeah, absolutely. So this is something I looked into. What the data shows us right now is that there is not expected to be a worsening of mood symptoms using the IUDs, right? And that includes both copper and the ones that have like a progesterone amount in it. And I think that makes sense, like pathophysiology, right? Because like with an IUD, there's a certain amount that's consistently released of the progesterone. And then particularly in IUD is a more localized release of it as well. And so it's believed that you're not going to see those, again, those changes as you normally would if someone was going through their normal menstrual cycle. And so it's not expected to worsen it. I couldn't find any studies around if it actually improved the symptomatology, but I imagine it would, right? I would warn patients though that likely in the first 3 months, the amount that's released is a little bit more erratic. It takes a period of time for it to really kind of even out. And so those first 3 months might be a little bit more confusing to them, particularly because the hormonal shifts that they see may not actually match the cycles that they're used to previously with like their normal menstrual cycle. So just being aware of like those first 3 months can be a little bit tough on patients. And that's something I have definitely seen. But after that, it tends to kind of be smooth sailing. Yeah, but I'm not sure if anyone has seen kind of different things.
Yeah.
I'll just,
Sure, go ahead.
sorry, I'm a women's health NP, so I see this all the time. The hormonal IUDs with the Mirenas, which are the higher dose ones, and the Liletas, there's a small percentage of women, it's under 20%, who do become fully suppressed. So their cycle, it's almost like being on a continuous OCP for a year or so is the estimate. So for a small portion of women, there's the chance that it could stop those hormone fluctuations that cause the worsening of the mood symptoms, but it's definitely not something that they can bank on. But it is something that I've seen helps a small percentage of people.
Yeah, thanks, Julia. That's really helpful to think about it that way. Just clinically, because I think individual responses to hormones are very idiosyncratic, and there are some people who are like super sensitive to progesterone. I have had some women get the IUD placed and then have become really dysphoric to the point that they had it removed. And I don't think that's necessarily reflected in the data, and it's possible had they waited it out, it would very likely even out, and they may not have the same feeling, but it was significant enough that they were willing to like go through the process of getting an IUD removed, which is not trivial either. And so I'd say, on a statistical basis, the data doesn't support it, but individuals may be very, very sensitive. And in terms of improvement, like I've definitely seen that for some people, it definitely improves it. Other people, it's sort of like, it improves it for a while and then they don't get their period, but they feel like they're cycling even through the IUD. And then it's sort of, they don't have a period as a marker when it's over. They just have to kind of keep track on their own. I think it's tricky, right? Because it's hard to know without a period, like what really is going on in terms of hormone fluctuations versus other sources of distressing stressors, essentially. So, but I think it's possible it could help. It also, if you have someone who you're doing ovarian suppression with, like a GnRH agonist, and you're going to do add back estrogen, one strategy to protect the lining of the uterus and to avoid having to do periodic progesterone is to have a progesterone eluting IUD to protect the lining of the uterus, and then you can do continuous estrogen dose. Anyway.
Can you explain how progesterone only birth controls work on estrogen levels, or do they go up and down on its own?
What I want to know is why are the IUDs progesterone only? Why have they made it that way? Because it sounds like, I'm just curious. I guess I don't know enough about this specific of like, why do they have it that way? Especially if some people are progesterone sensitive.
Mm-hmm. So my understanding of this, and definitely would appreciate Betsy's input here, is in general, like when we're thinking about like the purpose of contraceptive methods is to like decrease the chance of pregnancy.
Right.
And progesterone in of itself is like enough to do that. right? And so the idea is like we want to like limit like the amount of hormones given to someone, and so you use just progesterone. And then estrogen comes with its own potential risks, so things like blood clots. And so we use sometimes just like progesterone as like one of the primary options, and that's enough to prevent any type of contraception.
Then what if anything happens? Like does the regular sort of cycle of what happens, because we know when you were showing when you're providing low baseline estrogen and progesterone with the pill, it's like it doesn't go through the fluctuations. What I want to know is what happens to the estrogen if you're just providing a low dose of progesterone. So you're obviating like the drop, like you're not having that sort of mood responsiveness, but like, does that change how the estrogen courses through your body? And is that better than having a low dose estrogen all the time? I'm just a little confused about this stuff.
No, absolutely. And that's actually, I tried to find like a graph that would show that, and I honestly couldn't. It was a question I had for myself. But in general, though, these the progesterone only contraceptions often are able to stop ovulation of themselves, which is going to stop kind of like it's going to make a change in the amount of estrogen that's actually in the body. But I honestly, I could not find any information showing us exactly what those estrogen levels are like, because they're not going to be exactly the same, right? And so it's such a tricky thing to like fully understand that.
Yeah. You could also get sort of partial suppression, right? Where you're not necessarily fully suppressing the cycle, and you might get some breakthrough cycles and some not with it. So but the base, like that, there is some level of suppression that can happen. I mean, and the other reason you use progesterone and not estrogen is that it's anti-proliferative.
Right.
So it protects the lining, right? So you're not gonna
not making it thick,
be able to receive to implant, even if there were fertilization.
Oh. Okay.
And Emma, I see that you had a question here too. Do you want to say that out to the group?
I was just wondering, I have a lot of patients in their 50s and 60s now going through menopause and having many psychiatric symptoms, but I was hoping that some of them would abate actually in menopause. I was wondering if you know anything about what happens when the hormones actually deplete and go down, and whether we see any, you know, whether that's just a specific psychiatric population that I happen to see, and in general, people have more of a remission if they've been PMS or PMDD sensitive.
Yeah, absolutely. So one, I would love to do more of a talk on menopause, and probably will do that later this year. But in general, when we think about kind of like the risk of having like more kind of like depressive symptomology in relation to menopause, that tends to be in like the perimenopausal period and kind of like early menopausal period, where we still expect to see like a little bit more fluctuation of hormones. And so there's still this idea that it's related to the fluctuation amounts of it that might be potentially worsening some of the symptoms. And then we know that like using HRT, or the hormonal replacement therapy, is actually quite effective and something that overall is like safe for individuals. I forget the exact amount. I think it's like 10 years within the period of like the onset of perimenopause, and that's something that can be used safely. And then in terms of kind of like that more post kind of menopausal period, I don't know so much of the data around kind of like changes in the risk of having like further depressive symptoms. I'm gonna let Betsy answer that one. I imagine it tends to decrease though, because you're not seeing as much of the fluctuations there.
Yeah, I would say that, you know, for sure the perimenopause is like an increase in symptoms for people who are hormone sensitive, but like at post-menopause, many of those women, there's not great data about this. They don't, you know, as Cecilia knows, they don't do great studies of women in later life with that, but just empirically, you know, now once you've navigated through perimenopause, many women's like feel better because they're not having that cycling. And if, you know, just looking also, perimenopause is a higher risk time for new onset depression. So even people who've never had a depressive episode in the past are at higher risk than when they're in menopause than not having new onset depression. But if you've navigated past perimenopause and to the like postmenopausal phase, like the risk goes down, and that's sort of where like risk of depression between men and women also in later life kind of starts to coincide.
Thank you very much.
I also have a question. First of all, thank you so much for the talk. I learned so much from your presentation. My question is specifically about managing patients who have bipolar disorder with perhaps continuous dosing with intermittent increase of the mood stabilizers that they're already on. For example, from what you said about the VPA decrease by about 30% with estradiol, if a person is going through regular menses, then their natural fluctuation of estradiol will also affect the VPA level. And so like a specific clinical example of how to increase VPA versus someone who's on lithium may not be so effective. Could you explain that?
Yeah, so I think the best way to think about it is if they're not on any type of oral contraceptives, right, then what you're trying to treat is like the worsening of symptoms during that luteal phase, right? And so based on the evidence that we have, it's more about like if you start during the luteal phase and you increase it then, that likely should cover some of the additional symptom severity that you see during that period. Right, that's again related to that changing in the fluctuation, because I didn't show it too much, but on that graph where it showed like the progesterone was going like this, so was the estrogen as well, right? And so you would treat more during that period and test it out with your patient. Okay, but that would be the best way to kind of do it for both Depakote or lithium. It's less about how much the medication is changing the dosing on it and more the symptoms that they might be experiencing during that luteal phase.
Yeah, with no exogenous hormones, I would not modify the dose just based on expectation of difference in medication levels, because it's not so clear with the levels of fluctuation in a normal menstrual cycle without going through first pass hepatic metabolism, which is where the glucuronidation pathway can get involved too. So, you know, in the levels in the amounts of hormones that are pumped out during pregnancy, which are multiple fold higher, yes, you do have to worry about it. But in a unmedicated menstrual cycle with just endogenous hormones, we don't necessarily think about changing medication doses based on just those levels. But as Nicole was getting at, the symptoms for people who are hormone sensitive, you may need to adjust to the mood stabilizers to deal with the symptoms. But most of our meds, like if you have someone on Depakote, they should not be in a situation, unless they have an IUD in place, they should not necessarily be in a situation where they're menstruating without any hormones. Sorry, just have to put that out there for everyone.
And then I guess like the other piece of your question was for like any changes with like OCPs. Again, we talked a little bit about hormonal estrogen and the changes there and being mindful during like those 7 and active day periods. For valproate, there really isn't any like specific guidelines, and it's really just kind of like following it with your patient and making adjustments as needed. Okay, but the risk of there being toxicity during like an inactive period with Depakote, it's much lower. You need really high levels of Depakote to get like a toxic reaction. And so clinically, it's not something that we've seen. We haven't seen a need to decrease Depakote during the inactive pill phase. Cool. Wonderful. Any last comments or questions, guys?
Thank you so much.
Bye, guys.